at 4:30 in time for our weekly Gecko session, hosted by the Gastro Foundation of Sub-Saharan Africa in conjunction with Project ECHO. We have 87 registrations this afternoon from 15 countries in Sub-Saharan Africa and interest in Saudi Arabia, Bangladesh, and Australia. The chat is open for questions, and we encourage you to post them. Should you want to ask questions in person, you're welcome at the end of presentation to unmute and put on your video and ask your question verbally. So it's a great pleasure this afternoon to welcome Dr. Tim de Maayer, who runs the Gecko Pediatric Gastroenterology sessions that we've introduced into our Gecko program. And Tim is from the Department of Pediatrics and Child Health and at the Regina Musa Hospital in Johannesburg. And this afternoon, I'll be talking about pancreatitis in children. Over to you, Tim.
Thanks so much, Chris. I'll switch everything on briefly. Okay, Cheryl, can you confirm that my slide is in the proper presentation mode?
Yes, it is. We can carry on.
Thank you so much. Chris, thank you very much, and thanks for this opportunity. I think it's exciting to have a pediatric session. I see lots of my colleagues from across the continent, and I'd just like to say, please be in touch with me and let's see how we can grow this initiative, because I think there's a lot of research that's begging to be done, and I look forward to collaborating with you. So I'm talking today about something that I'm certainly not an expert at, pancreatitis in children. I think a lot of the time we learn from our patients, and this is a case in point. So I want to share with you a little journey of a patient that we had in our ward recently. And that cup of coffee was for Cheryl, but I think maybe it should be a glass of wine, because that can cause pancreatitis, of course. So a few weeks ago, we had Mr. LM presenting to our hospital. He's 8 years old. He had a history of abdominal distension and vomiting. It was quite vague as to when it started. He'd actually been staying with his maternal grandparents in rural Zimbabwe, and there wasn't much in terms of history other than he was okay until probably late last year, and then started having this abdominal distension, which was intermittent and had now gotten worse. So his parents brought him to South Africa. On examination, so it's starting with anthropometry, like you like to do in pediatrics. I think what's most marked is that his mid-upper arm circumference for his age was less than -4 Z-scores. So he was significantly wasted, even though it wasn't reflected in his BMI for age. And that's probably because he had quite a lot of ascites contributing to his weight. On exam, he really looked chronically ill. He was obviously wasted but not jaundiced, no clubbing. And then he had this distended abdomen without any dilated veins, full flanks, and an obvious fluid thrill. We were unable to palpate any organomegaly because of the tense ascites. So I stopped at this point and just thought the causes of ascites in pediatrics are slightly different to adults, of course. So this is what usually goes through my mind when I see a child with an ascites of unknown cause. So the vast majority of our patients are due to cirrhosis and portal hypertension. We do have a lot of end-stage liver disease patients that get referred to us, and quite frequently they'll have severe ascites as a result. But we always think about nephrotic syndrome, and we always think about doing a urine dipsticks and an albumin. We think about peritoneal causes. This is Africa, so we think about TB a lot, and other causes of hypoalbuminemia. But perhaps specific to the pediatric group is this uroascites, which we've seen a few times as well, usually as a result of an obstructive uropathy, something like posterior urethral valves in baby boys that causes rupture and ends up with ascites with a high urea value. And then we've seen a fair amount of chylus ascites, and just the other day we had a child with biliary ascites as well. So a variety of causes, and that child was probably as a result of a ruptured choledochal cyst that had been missed. So obviously everything hinges on the diagnostic paracentesis, and what I often get asked is, one, is it safe to do in this child? Because we're often talking about liver children with coagulopathy. And then what must I send it for? So in terms of is it safe, I always say it's safe as long as there's no frank DRC. So INR and platelets, according to the literature at least, don't really matter in terms of a diagnostic tab, and should be quite safe to be done. What do we send it for? So the obvious is cell count and microscopy. We always send that. We always send it for culture as well. Reading a bit of the literature, actually, one of the things that I took home from this is you should probably send it in a blood culture bottle rather than in a tan top tube or an empty tube, for a better yield. So that's something to take forward in my practice personally for the next time we have a query bacterial peritonitis. And then the usual chemistry that we do is albumin and total protein. We no longer use Light's criteria, but if we think further, then we might do a glucose to look for infections. We might do an amylase, look for TB, etc. And then sometimes if we think there's something weird going on, we'll send for triglycerides, bilirubin, and cytology. So our patient on his general bloods had a bit of a neutrophilia. He had a markedly high CRP and ESR, and his albumin was low. So of note, his LFT was completely normal, his CMP was normal, and we never cultured anything on his bloods. His acidic fluid showed numerous neutrophils. Unfortunately, they didn't give me an exact count. They didn't culture anything, but it certainly looked like this might have been a bacterial peritonitis on top of whatever was causing the ascites. So the chemistry showed a total albumin of 17, which means the serum ascites albumin gradient was 10, which is lower than 11. So we're dealing with a low albumin gap ascites. And then his glucose was also low, supporting the thought that this might be bacterial peritonitis as well. So I said we no longer talk about Light's criteria. We don't really talk about transudates and exudates anymore. We look at the gradient, and this is obviously a child with low gradient. So we think about TB, we think about nephrotic syndrome, malignancies, pancreatic ascites, and the others that I've mentioned. So luckily someone had sent the fluid for other tests, and this is what we found. There was no protein on his dipsticks in terms of nephrotic syndrome. There were no malignant cells in the fluid. The TB gene expert was rejected, but the TB backtick is currently still negative. And then we found this markedly high fluid amylase, and suddenly started thinking about pancreatitis. So we quickly did a blood lipase, which was more than 3 times the upper limit of normal. We did this triglycerides to check for secondary pancreatitis, and that was normal or low. I already said his calcium was normal. And just to confirm, his HIV negative, and the rest of his TB workup was also negative. So we went over to imaging, and this is not his ultrasound, but I'd like to just go through it because I think it's important in terms of interpreting some of the other images in the talk. And I think in our experience, we've really been doing a lot of ultrasounds ourselves without any experience, but just a little bit of reading and a lot of practice. And you often can get remarkably good ultrasound images yourself and start interpreting them. So I know we recently had a point of care ultrasound talk, and I really think it's something that we should all be practicing. So this here is a transverse view of the epigastrium. In an adult patient, you would ask them to take a deep breath and to hold it so that you're pushing down the diaphragm a bit. In pediatric patients, that's not so easy. So in this view, we see anteriorly the left hepatic lobe. Posteriorly, we'll see, let me get my pointer. So, so we see the aorta, and we see the RVC, and then just we pan up and down until we see anterior to that, the superior mesenteric artery and the splenic vein lying across that. And once you've got that view, you hopefully can see the pancreas in a longitudinal section. So the head of the pancreas, the body of the pancreas, and the tail. And granted, this is often not as easy as it looks on this picture, because often you've got intervening bile gas, but with a bit of manipulation, we can often get a nice image like that. So the sonar on our patient showed simple ascites, no lymphadenopathy in terms of TB. There was an irregular pancreas, but no calcifications, and a normal gallbladder, and the bile ducts were not distended. All right. This is what you might see on in terms of abnormal ultrasound on the pancreas. So on the left, we've got acute pancreatitis, and you can see that the pancreas is swollen, is brightly echogenic, and has got some fluid around the pancreas as well. And then on the right, this is chronic pancreatitis, and the telltale sign here is these diffuse calcification, which is, confirms that this is quite end-stage chronic pancreatitis. So unfortunately, we're having issues at the moment in our hospital. Our CT scan is broken, so we had to send the patient somewhere for a scan. And now I'm struggling to play the video. Bear with me a second. Okay, I doesn't want to get rid of my pointer.
If you just stop the share and come and then start it again.
I'll do that. Sorry about that.
Don't worry, Tim, we have plenty of time.
Okay, that's better. So this is someone taking a video of the screen of this CT scan that was done, and I'm going to let it play, and then we'll scroll back and see what we can see. So you see the liver there, antrum of the stomach coming into view. The bright spot is the aorta, kidneys, and there's a splenic vein and the pancreas anteriorly. And that's more or less where I stopped it. So let me just go back. So what you can see here is that view that we had in the sonar earlier with the splenic vein emptying into the superior mesenteric vein. I'll get my pointer out again. Oops. So that's the superior mesenteric vein, splenic vein, and the pancreas overlying here is quite bulky. And what you can see on this particular image is this irregular border of the pancreatic duct. And that sort of convinced our radiologist that this was pancreatitis. Was chronic pancreatitis, I should say. Scrolling further down, you see a little bit of the tail. There was no overt necrosis and like we said, no calcifications. So that was his scan, and that was our patient. And it made me think about pancreatitis, which is something that we don't often think about as pediatricians. So I told Chris, I gave this talk to some of my colleagues last week, and most of them said, we haven't thought about pancreatitis since we were an intern in the surgical wards. And we really, in pediatrics, don't think of it, and hence maybe we miss it. So I decided to read up on pancreatitis. So most of what I'm going to present is from this group called the INSPIRE group. And as with any rare disease, it's good to have a multi-center group that looks for all the patients with pancreatitis and comes up with definitions, etc. So INSPIRE, I don't know how they got INSPIRE from International Study Group of Pediatric Pancreatitis, but they did. And they're mostly situated across the US, Canada. They've got a center in Israel and also in Australia. And the aim really is to investigate the pathophysiology in children. They came up with definitions and hopefully some prospective trials coming out. So one of their first publications was this definitions of pancreatitis. And I think this is quite important. So firstly, when we look at acute pancreatitis, you need 2 of 3 criteria. So abdominal pain suggests or compatible with acute pancreatitis, but what I need to highlight here is that it's actually seldom that in pediatrics you get this typical pain that radiates to the back. Some of the literature I saw said only 20% of children with acute pancreatitis have pain radiating to the back. So we really need to think carefully when we have a child with severe pain and especially epigastric pain about pancreatitis. So then serum amylase and lipase, more than 3 times upper limit of normal. There are many causes that cause a slight elevation that are not consistent with acute pancreatitis. And then the imaging findings, and generally ultrasound is the first step. And hopefully we can visualize the pancreas. We've also got acute recurrent pancreatitis, and for a patient to have acute recurrent pancreatitis, you need 2 episodes or more, but you also need complete resolution between the episodes. So this is not one prolonged episode of pancreatitis, this is 2 distinct episodes. And then chronic pancreatitis. Chronic pancreatitis really is an irreversible version of acute pancreatitis. So you need to have a histopathological features of chronic pancreatitis, like fibrosis and necrosis, or since we generally don't have biopsy specimens, you need both radiological evidence of chronic pancreatitis and abdominal pain, or evidence of exocrine and endocrine insufficiency. So any of those must or is sufficient to make you diagnose acute pancreatitis. So just to highlight that there are many causes of an increased lipase and even more of an increased amylase. We know amylase is also from the salivary gland. There's an entity called macroliposemia, where lipase polymerizes with other proteins and is not filtered properly through the glomerulus, so is falsely elevated. And that's another thing we need to think about. And yeah, so then pancreatitis in children, and this INSPIRE group really said that it's been underestimated. And I always thought that it was rare as rocking horse manure. So there's a study from Pittsburgh that looked at the historical incidence of pediatric pancreatitis from 1993 to 2004 and saw a dramatic rise in the incidence, and that correlated directly with the amount of lipase tests and amylase tests that they ordered. So they think it was mainly because people weren't thinking of it, that they were missing acute pancreatitis. And just of note that 13 per 100,000 children is actually pretty close to adult incidence. So really highlighting that we should be thinking of it, and we may be missing it at times. So talking a little bit about the management of pediatric pancreatitis, and there's very useful consensus guidelines. This is from the North American Society Pancreas Committee, and they recommend not using the scoring systems that adults use. They prefer using the systemic inflammatory response syndrome criteria to predict organ failure, and they also predict suggest using lipase more than amylase because fractionated amylase is not widely available. So once we've made that diagnosis of acute pancreatitis, we need to think about what the cause is. And obviously alcohol and smoking is not as common in our age group. So some of the things, I think the thing we mostly think about or immediately think about is viruses, and especially mumps. But there's many other viruses and infections that can cause it. there's a host of drugs that can cause it, and this really made me think. I think most of us will remember the early NRTIs have got a good chance of causing pancreatitis. But if we look at some of these drugs, we tend to use them a lot in our patients with inflammatory bowel disease and autoimmune hepatitis. And a lot of these children will present to us with pain and abdominal pain. And I'm not sure that I've always thought about pancreatitis and done the necessary bloods or sonars. So sulfasalazine 5A is azathioprine drugs that we often use. Epilim's a drug that we use all the time. So there's quite a lot of them. We've mentioned before the metabolic causes, hyperlipidemia and hypercalcemia. There's a lot of mechanical causes which we'll go into with chronic pancreatitis. There's trauma, so the surgeons know about acute pancreatitis in that type of child. And then there's post-ERCP. So in children, ERCP is likely to cause acute pancreatitis as well. So lots of things we have to think about, in the genetic mutations I'm going to talk about with chronic pancreatitis. So in a case series, looking at the causes that they found in their population in acute pancreatitis, still the majority were idiopathic or other. So a lot of the time we're not actually diagnosing what caused this acute pancreatitis. I'm going to briefly touch on management because we're not used to managing acute pancreatitis as pediatricians. The hallmark or the most important part of management of acute pancreatitis is really fluid management, and crystalloid management is preferred. You bolus them until they're hemodynamically stable, and then what's important is to give them over maintenance requirements for the first 24 to 48 hours, and that has really been shown to improve outcomes and thought to increase the perfusion of the pancreas. So study on the right here is a retrospective study of 200 patients, and what they really showed is what the adults already knew, is that children who received feeds earlier and had higher amounts of intravenous fluids had a better outcome. And I think that's changed completely from certainly when I was a medical student and last saw pancreatitis, when we had these patients staying in the wards for many weeks with a nasogastric tube and nilpa-os, and we're far more aggressive in terms of feeding them now. So just to finish with nutrition on the right side, so the recommendations, if it's mild, you're going to feed them as soon as possible. But even if you've got moderate or severe pancreatitis, you should aim to commence feeds within 3 days. And it should be gastric feeds. It shouldn't be jejunal unless they're not tolerating. And it can be a polymeric formula. It doesn't have to be hydrolyzed. And if you're still unable to give nutrition within 5 days, that's when you use parenteral nutrition. But that should really be the minority of patients. Another big thing with acute pancreatitis is the management of pain. And the guidelines all suggest involving pain specialists and treating pain aggressively, because it can become a chronic problem, and especially if you progress to chronic pancreatitis. Other things that are not recommended in acute pancreatitis is prophylactic antibiotics, antioxidants, and early referral to surgical facilities unless there's trauma or biliary pancreatitis. Some of the complications, even in acute pancreatitis, we can see pancreatic fluid collection, pseudocystic necrosis, and venous thrombosis. And in severe pancreatitis, you can have multi-organ failure. So the next thing to look at then is acute, recurrent, and chronic pancreatitis. And this paper from the INSPIRE group from 2016 really gives us a good insight into these patients in pediatrics. So firstly, there's evidence that between 9 and 35% of children who have acute pancreatitis will have another episode, making them acute recurrent pancreatitis. And with acute recurrent pancreatitis, if you have it a few times, this puts you at risk for chronic pancreatitis. And there's several risk factors which we're going to go into. So the INSPIRE study group came up with a study of nearly 300 patients, and in the majority of those with chronic pancreatitis, they had previously documented acute recurrent pancreatitis, and obviously there were a whole lot that might have been missed. So the thinking is that the vast majority, if not all patients with chronic pancreatitis, got there through acute recurrent pancreatitis. So the main risk factors that we see in children are genetic, obstructive, and then toxin and metabolites not as commonly, and autoimmune pancreatitis really quite rarely. So I want to just talk briefly about all of these. And the biggest one really is the genetic risk factors, which I think is a relatively new thing, in that certainly when I was studying, we didn't think of pancreatitis as a genetic disease. And in this particular INSPIRE group, they actually saw that 73% of their chronic pancreatitis patients had an identifiable gene mutation. And that is despite the fact that they didn't actually test each and every patient for all the gene mutations that they had, and the fact that since this publication, there have been more genetic mutations that have come to light. So the ones that are well known as the cystic fibrosis transmembrane conductance regulator, so the same one that we see in cystic fibrosis, but there's also PRSS1 and SPINK1, which are both implicated in to be risk factors for progression of pancreatitis to chronic pancreatitis. And there's some other ones. So the genetic field certainly has been moving at a rapid pace. We also mentioned briefly the obstructive causes, and pediatricians, we always like our embryology. So this is a picture of the embryo with a primitive foregut, and the pancreas consists of a ventral bud, or originates from the ventral bud and the dorsal bud. Ventral bud rotates posteriorly to lie underneath the dorsal pancreas, and has got a separate duct which usually fuses, and you'll see on the left side, that's the normal fusion of the ventral and dorsal pancreatic ducts. And when they're not fused, if they're incompletely fused, then that's a pancreas divisum. And the thinking is that that predisposes you to chronic pancreatitis. So this is a slide looking at what they found in their patients. So we've already spoken about the genetic risk factors. 33% had an obstructive risk factor, which you can see there. They had a fairly high amount of autoimmune pancreatitis, which is very unusual for pediatric series. And then they had the toxins and metabolins that we've talked about, specifically the medications. So a word on autoimmune pancreatitis, because this is a very rare entity which we don't generally think about. And I think it's quite different to adult autoimmune pancreatitis from what I could read. It's infrequent, like I said. They may actually present with a normal amylase and lipase, and the gold standard for diagnosis is histopathology, which is obviously not easily gotten, especially in children. One of the hallmarks of disease in adults is an elevated IgG4, but in fact in pediatrics, there's many children with autoimmune pancreatitis that don't have an elevated IgG4. And then we've got some other autoimmune markers, but again, there's very little data in pediatrics to say how commonly these are positive. In adults, you get type 1 and type 2 autoimmune pancreatitis, but in pediatrics, there's frequently overlap between the two. And the hallmark of autoimmune pancreatitis is there's a rapid response to steroids, although the use of steroids is still controversial because they tend to resolve on their own as well. And then they're also frequently seen with other autoimmune conditions like Crohn's disease or celiac disease, etc. So quite a strange entity, I think still very poorly understood in pediatrics. And for me, this would really form a big diagnostic challenge in our setting. I'm not sure how we would actually manage to detect this apart from blindly starting steroids in a patient with acute pancreatitis, which is obviously, or with chronic pancreatitis, which is obviously not ideal. So talking a little bit more about the imaging, and I think in pediatrics, we like MRCP a lot, because it's not as invasive as ERCP or an endoscopic ultrasound. There's also very little expertise in pediatric ERCP. And so we rely on our radiologists. But having said that, unfortunately, even the MRCP, particularly in small children, can be quite difficult to obtain. And certainly in the VIT setting where I work, we struggle to get our radiologists to agree to do an MRCP in a young child. They need a general anesthetic. They need a good pediatric pancreatitis protocol for the MRI, and then they need a good radiologist to interpret it. So we struggle with it. But the pictures that you get are quite beautiful. And just a few examples here, intraductal calculi on the left, and then this very irregular duct with strictures on the right, showing the hallmarks of chronic pancreatitis. So what should we be using in terms of investigations for our children with pancreatitis? This is a survey of pediatricians that see a lot of pancreatitis and what they would order. So for acute pancreatitis, I should say, they all do a sonar, they all do an LFT, and a majority of them will look for triglycerides and calcium to look for secondary causes. And really the majority of investigations only used in children with acute recurrent pancreatitis and chronic pancreatitis. So here, a majority will do some form of imaging, whether it's CT or MRCP or a secretin induced MRCP, or in fact an ERCP if you've got the facilities and the expertise to do so. Majority will also send genetic panels and do a sweat chloride to look for cystic fibrosis. And that's similar in the chronic pancreatitis group. So I think that gives us a good idea of what we need to do for our children. And then we need to think about the consequences of chronic pancreatitis, because this is, I think, a very challenging field. And I'm quite grateful that we don't have many of these patients, because reading up on the management really sounds like a challenging topic. So firstly, pain management. Pain can be a severe or can be a very difficult thing to manage in children with chronic pancreatitis. We start off with this pain ladder. So we start off with the non-opioids and move up as needed. And really, if you've got severe pain, you'll need to look at neuromodulators. You need to look at possibly celiac plexus block if you've got that expertise available in your center. Lots of people use antioxidants. Antioxidants as a mean of managing pain in chronic pancreatitis. And although the evidence is very weak, it's something that's quite easy to do. And lots of people will give high dose antioxidants to try and relieve some of the pain as well. Exocrine pancreatic insufficiency is something that's quite interesting to me, and I've put this slide in. There's a review in how to investigate exocrine pancreatic insufficiency in children, and the two big groups of things that you can do are either indirect tests or direct stimulatory tests. And the indirect test that we usually do is a fecal elastase 1. But having said that, we know that it's quite non-specific and that it's not very sensitive either, so it won't detect early loss of pancreatic function, will only be positive quite late in the disease. And similar with fat, 72-hour fat collection is obviously very cumbersome and not often done, and other measures might not be that accurate. You can look for nutritional markers. We can do the fat-soluble vitamin levels and that sort of thing. But again, it's an indirect test. Breath testing and urine testing is really not used in a clinical setting. But then there's this exciting role that, and I think upcoming role for exocrine pancreatic or endoscopic pancreatic function tests. And the picture up at the top is where you intubate your duodenum, you give secretin intravenously, and then you aspirate the secretions and you analyze the constituents of the pancreatic secretions and the bile and measure the amount of enzymes that you've got available. And that, I think, in future, for now, there's probably very little data on the normal values, but in future that should be a useful addition to our testing. I want to mention nutrition in chronic pancreatitis. Our patient particularly was severely wasted. And what are the recommendations? So the recommendations are not to give a low-fat diet. The recommendations are to give a diet with normal fat, to monitor your fecal elastase every 6 to 12 months, to look for insufficiency, and if there is, then you use pancreatic replacement doses the same as in cystic fibrosis. We should be monitoring our fat-soluble vitamin levels to look for complications and monitoring our bone mineral density, especially in a growing population such as our children. So again, this study looking at therapeutics from the same INSPIRE group. It's the same study that I mentioned earlier, and this is the sort of interventions that they use. Some pain medication. The majority of children with chronic pancreatitis, pancreatic enzymes and medical therapies, and a lot of them antioxidants, not as popular. ERCP in some centers is used extensively, and obviously both for intervention as well as diagnosis, and stenting where available, and then surgery, which we hopefully will not have to use unless we really have our backs against the wall. So I wanted to briefly touch on the role of endoscopy in chronic pancreatitis, because in adults this is used frequently, and obviously pediatrics is always a little bit behind with this sort of thing, and we lack the expertise, and we lack the equipment, and we lack the standards and the accepted normal ranges of values for things that we find in our endoscopic ultrasound or ERCP. So the guidelines say you should be able to use an adult endoscope for children above 10 kilos if you're going to do ERCP, and endoscopic ultrasounds you can use in children over 15 kilos. I've got no experience with it. I did inquire with our pediatric surgeons what the expertise is like, and they do refer to the adult ERCP specialists that do some of them, but I think it's obviously far from ideal. And if it comes to stenting and that sort of thing, we're gonna struggle to find the right size. We're gonna struggle to get the correct materials and the correct procedure without causing pancreatitis, which is one of the big worries that we have. So certainly it's not advised for diagnosis blindly unless you've got other evidence of chronic pancreatitis, and then it really depends on the experience you've got in your center. So endoscopic ultrasound, diagnostic capacity in adults is almost the same as ERCP. New kids on the block are ultrasonic elastography and contrast enhanced endoscopic ultrasound, but in pediatrics there's no data. It's very useful to get biopsies or FNA, and in terms of autoimmune pancreatitis, I think this is the way that you could diagnose it if you've got the facilities. And then you can do some ultrasound guided interventions, including draining of pseudocysts and placing pigtails from the cyst into the stomach. And even in the management of chronic pain, some experts can put celiac plexus blocks as well. The risks of endoscopic ultrasound are much lower than that of ERCP. Obviously, you do need a general anesthetic in pediatrics, but apart from that, you worry about perforation, infection, and pancreatitis. And these are some of the images which really look quite amazing. Left top, you see the pancreatic body with a normal looking duct coursing through it. left bottom, there's a big calculus sitting there in the pancreatic duct. Body of the pancreas is pointed out in the right top hand picture, which is apparently normal, but in picture D, you see lots of calcifications in that body. So that's abnormal. So that's the sort of picture you can get with endoscopic ultrasound. And these are pictures of of necrosis on the left, and then of a pseudocyst, the picture in the middle and on the right. In the right-hand picture, they've actually included, or they have inserted a pigtail to try and drain it into the stomach, which is what the arrow shows. So ERCP, I've mentioned MRCP is far more used in pediatrics, but MRCP doesn't give you the therapeutic options. With ERCP, you've possibly got the option of doing sphincterectomies. You've got, you can manage this, ductal strictures, you can take out stones, and you can manage fluid collections. Post-ERCP pancreatitis is seen in 5 to 10% of children that have ERCP. So that's quite high, and sometimes that can be moderate to severe pancreatitis as well. So it always has to be taken into account. It seems to be related to procedure time and the time taken to cannulate the ducts and the amount of contrast that you inject, etc. So you really need an expert to run your ERCP services in children. And this is a picture of an ERCP, picture A showing that pancreatic duct, which is very irregular with some strictures. Same in picture B with a dilated duct, and then filling defects in picture C signifying stones in the pancreatic duct. So last word on surgery. The picture on the left is the Whipple procedure, which is what I remember from medical school. It's used as little as possible in pediatrics because it almost invariably will render your patient with diabetes and with exocrine pancreatic insufficiency. So the approach in pediatrics certainly is a more conservative approach. That do drainage and partial resection, but probably not as severe as a Whipple procedure. And then there's this very exciting new therapy, which sounds like it's from the future. It certainly is for us here, but it's used overseas, and that's the total pancreatectomy and islet cell autotransplantation. So they take out the pancreas, they're minced up, they take out the islet cells, they inject those into the portal vein, and picture C is actually a liver biopsy showing the islet cells in the liver, having taken in the liver. And it seems like the earlier you do this and the younger you do this, the greater the chance of making this patient endocrine sufficient and actually not requiring any diabetes and only requiring exocrine pancreatic replacement, which is a good thing because the type 3 diabetics that you render through endocrine insufficiency are apparently very difficult to manage. So back to our patient, just to finish off. His glucose remained normal in the ward. We're still waiting for his fecal elastase and his chloride. We've sent off a mutation analysis for the cystic fibrosis mutation, and we're looking at the possibility of sending a gene panel test overseas. So a lot of the panel tests overseas either test for the 4 most common or the 6 or the 10 most common genes causing chronic pancreatitis. But to us, it just means that we have to raise some funds to be able to do this for our patient. And that is all I had to say. Finished in good time.
Excellent, Tim. Thank you very much for that absolutely crystal clear presentation. And really, I can see you're perfectly poised to drive pediatric gastroenterology and the teaching through the continent. And really, we will give you all the support you need. The foundation is really committed to contributing to the education of not only gastroenterology, but also in adults, but also pediatric gastroenterology. So thank you very much. So a couple of questions from the chat, from Wisdom in Zimbabwe, a couple of issues regarding the diagnosis. Firstly, pain wasn't really a presenting feature in this young patient. Was there any history of a past pain or any history that the patient had any significant abdominal pain?
So thanks, Wisdom. So yes, there was, but it was difficult because of, one, the language barrier, and the father not knowing any of the history at all. So it was really trying to get it from the 8-year-old child. So he had intermittent pain. He had been treated numerous times for with PPIs and laxatives as well. So yes, pain was there. I see there's also the question continues about how to explain the ascites, and really your guess is really as good as mine, I guess, on whether we missed some sort of collection or some sort of pancreatic leak that occurred that caused this chemical ascites. Certainly the very high lipase value or amylase value in the pancreatic fluid, I think, would suggest that, but we didn't find any other collections to explain this.
So Tim, on the basis of that, I mean, it's in adults, we would screen patients with unexplained abdominal pain with a serum lipase, an amylase, and perhaps a lipase. So is this something you would consider doing in neonates or in the pediatric population? And in fact, do you do it in patients with in pediatrics with pediatric patients with unexplained abdominal pain?
Yeah, so I think this is where my take-home message really was, I haven't been looking for it as actively as I probably should have. So the pain in acute pancreatitis obviously tends to be severe, and hopefully it will be a minority of patients that present with more vague pain and chronic pain. And I guess generally most of our children will get at least an abdominal ultrasound. But then with abdominal ultrasound, we frequently have reports of not seeing the pancreas because of bile gas intervening, etc. And I don't think we always think about lipase and amylase. I certainly, like I mentioned on the drugs that might predispose you, I certainly haven't thought about it in all the children that we're treating for autoimmune conditions and inflammatory bowel disease that have frequently got abdominal pain. I guess the pain tends to mostly be epigastric, so that should worry us, and tends to be persistent and severe, then we really should be thinking about chronic pancreatitis. So certainly my take-home message was that I need to test it more often, and I'm pretty sure I've missed some of them in my practice.
And then, as you can see, there's some questions regarding management. Would you consider using antibiotics in pediatric population with acute pancreatitis?
Yeah, so the literature is quite clear. There's no role for prophylactic antibiotics. Having said that, we did treat our patient with antibiotics because of the peritonitis, and with very good response. He recovered quite amazingly and developed a voracious appetite. Yeah, so I think certainly he had a secondary infection. So, but in absence of that, no, there's no role for antibiotics.
And then a question about the role of chronic malnutrition in the etiology of chronic pancreatitis.
Yeah, so I think we see lots of chronic malnutrition from a variety of causes, and generally these are not patients that will develop pancreatitis as far as I know, and again we might have missed him, but definitely the other way around. So we had a talk last time on this platform about cystic fibrosis, and one of the things that we need to think about is cystic fibrosis induced pancreatitis, and these children might present with chronic malnutrition. And obviously chronic pancreatitis is certainly a cause of chronic malnutrition, and we should be aware, and we should be thinking of doing a fecal elastase, which is another useful test that I've been using more often.
In fact, reading in pediatrics, in fact, in adults, more an elevated BMI might be a predisposing factor to pancreatitis rather than malnutrition. And I was quite surprised to read that, in fact, in the US data, this obviously applies to adolescents and not to younger patients, but smoking and alcohol consumption together with BMI play quite an important role in adolescents with pancreatitis. So it's the elevated weight, I think, that would be more important. Your comments?
Yeah, absolutely. So that was in that study from the Inspire group as well. They certainly saw some alcohol use and they saw some smoking. And like you say, obesity was one of the risk factors. I think we tend to, our cutoff for pediatrics is 14 years. So we see even younger children than they would see overseas. We see less adolescents, and perhaps that's why we don't see this as much. But yeah, I agree with you. Obesity is something that we need to think about.
And then there's a question, thank you, from Juliana Muiva. Excuse me if I'm pronouncing your names incorrectly. I have a 13-year-old who's had weight loss of more than 6 kilograms after an attack of pancreatitis, his second one. How would you advise the nutritional support?
So it sounds to me like he might well have endocrine or exocrine pancreatic insufficiency. So I think the first step would definitely be to do a fecal elastase. Having said that, obviously recurrent pancreatitis will cause you not to eat as well because of the vomiting and the pain and the nausea. So that might also play a role. The general guidelines, as far as I could read, is not to give any specific diet. So you use your normal fat-containing diet. You might supplement with fat-soluble vitamins, and you replace your pancreatic enzymes. And that's really the sort of cornerstones of nutritional therapy.
And then a question, and have you heard or have you read of an increased prevalence or incidence of pancreatitis in the COVID era?
So I haven't. I wouldn't be surprised if it was, but personally, I haven't seen it, and it didn't come across it in the literature that I read.
And then the course of steroids in autoimmune pancreatitis, I think in adults, very important to pick up this diagnosis because it's something you can do something about. I'm disillusioned that the IgG4 in the pediatric population is not a good screening marker, because we do rely on that in adults to make the diagnosis. But how long would you use steroids if you had to confirm this diagnosis?
I think, again, we probably extrapolate from adult data, Chris, so we do whatever you do. What I read is that it's less than 50% of children with autoimmune pancreatitis actually had an elevated IgG4. And to me, that's very worrisome, because I'm not going to get a pancreatic biopsy on my patient. And, you know, it's treatable, like you say. I think probably we would use a short course of high dose steroids and see what the response is. And then I know that the majority of them resolve and you monitor them. And if they do develop recurrent episodes, then you would consider immunomodulators. So things like azathioprine and that, which would come into play.
And then there's Liz, would you like to unmute and put on your video, ask your question? Nice to see you, Liz.
I'm battling to even find the video thing.
We can hear you, yeah.
No, I mean, there have been a few articles on children with malnutrition and a low fecal elastase benefiting nutrition-wise from the enzyme replacement therapy. And we've often found that when our backs have been to the wall with the nutrition, we've often given the Cree on spec. It's short term, but they do improve. And then I was just wondering, with your IgG4, do you think you don't see the levels raised in children because isn't it the last IgG to get to adult levels for children? So you might not have even got you know, they're very low levels in younger children. So I'm wondering if we miss that just because it takes longer for the IgG4 to mature to adult levels.
Yeah, thanks, Liz. Good points. I don't know. I agree with you.
Yeah, good point. Are there any other questions? I see quite a lot of my adult colleagues, anyone with experience that could extrapolate to pediatrics. Perhaps while we're waiting, I might just mention that this weekend we have our Fellows Postgraduate Program. This is dedicated to Fellows training in adult gastroenterology and hepatology. But we plan to reintroduce pediatric teaching to the Fellows training as pediatric gastroenterologists. The link will be sent out to our GASA network, which is online. And anyone interested, please email me or Cheryl. I've spoken to Tim about reintroducing a pediatric section as we had prior to the COVID year. It became a little bit, it disappeared a little during the last 2 years, but we plan to reintroduce pediatric fellow gastroenterology teaching to our program, which we have annually. So please look out for that link. It's free and you're welcome to join in and benefit from the live streaming. Whether you are an adult who sees a gastroenterologist who sees pediatrics, or even for pediatricians who want to learn from adults gastroenterology teaching. So it'll be this weekend, Friday to Sunday. Are there any other questions? It doesn't look down. Final comments, Tim, anything you want to end off with?
No, thanks, Chris. I see Sarah Birkenfeld has got her hand raised. I hope it's not a difficult question.
Sorry,
Thanks.
Sarah.
No, not all. I just have 2 questions. Sorry, Tim. My first question is to you, Tim. What would make us suspect an autoimmune pancreatitis that would prompt us to even give steroids? And my second question is actually to Dr. Goddard, and I just want to clarify, your experience with pancreatic enzyme replacement in children with malnutrition, is that children with malnutrition from general causes, or children with malnutrition secondary to chronic pancreatitis? And the interest from my side is I've had a patient before who was malnourished. We couldn't find a cause really, because he was an inpatient and being treated with continuous nasogastric feeds, but did have a low fecal elastase and did respond to replacement therapy, but was actually genetics for CF were negative. So I'm just asking around that.
Thanks, Sarah. Liz, I don't know if you want to comment.
Yeah, Sarah, it was general malnutrition, and it was published in the last few years in JPGN. So they had a series from Malawi, and so if the children with malnutrition had the low fecal elastase, they benefited from the replacement.
Okay, thank you.
But that's only if they had a documented low fecal elastase, is that right?
Yeah, no, definitely. Yeah.
Okay.
Yeah, and in terms of your first question, I really don't know. I was also a bit disappointed with when I was reading through autoimmune hepatitis. I didn't know how we were going to diagnose it. And apart from having a high index of suspicion, looking for other autoimmune diseases. And yeah, that's about it.
Or actually a diagnosis by exclusion, which is not really very good, but and that's how we began looking at it, and then came this wonderful test that we could do in the serum in adults. So, well, Tim, thanks so much once again.
Thank you.
Really wonderful presentation, and thank you to all the audience for your contributions, being online and giving us these wonderful questions, and starting this wonderful community focusing on pediatric gastroenterology. Thank you really much to ECHO New Mexico, the India team, the local team, Cheryl and Karen, for all their backup work, and also to our sponsors, for their support in hosting these meetings on a weekly basis. The feedback form is available, and we'd really encourage you to fill it out. And next week will be an endoscopy session. Sandy Thompson will present issues on large bowel bleeding, and a presentation on a patient with an acute abdomen which had a conundrum as a cause. So we look forward to seeing you back, and thank you very much to everyone. Good afternoon.
Thanks, Chris.
Thank you, Tim.
Thanks, everyone.